Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. We have a great show for you tonight, an excellent show. We're talking about obstructive sleep apnea. But before we get into the topic, I'd like to talk about caring and sharing. I'm telling you, all of the emails and all of the Twitters, that's what it's called, the Twitters that you sent me, I'm just loving it. I'm loving all the information that you're giving me about your health and your problems so that we can have the same topics here on this show and we can help you guys out there take better care of yourselves. It's all about it. www.medmoments.com. Don't forget the S. That's www.medmoments.com. And tweet me at medmoments. Alrighty, let's get to the topic tonight. It's called obstructive sleep apnea. And I have the greatest doctor, I should say. We go way back for many years, so I can call him a guy. But the greatest doctor to talk about this problem, Dr. Jeffrey Nahmias. He is the director of the sleep lab at Newark Beth Israel Medical Center. Dr. Nahmias, welcome to our show.
Thank you. It's a true pleasure to be here.
Oh, it's a pleasure to have you. Listen, this is such an important topic because so many people have obstructive sleep apnea. I want you to just lay it out for me and tell me, what is obstructive sleep apnea?
Okay. Obstructive sleep apnea is whereby when the patient is sleeping, the upper airway, the tongue falls back against the back of the throat and actually obstructs the airway. When that happens, of course, the patient no longer can breathe and he'll stop breathing from 10 seconds, 20 seconds, 30 seconds, all the way up to 2 minutes. When this occurs, of course, the oxygen in the blood goes dangerously low and it has serious consequences upon the body. And that's what's called an obstructive sleep apneic event.
Okay. Now, let's step back just for a minute. Apnea. Just give me a definition because I know that's a major aspect of this disease. What is truly an apnea?
Apnea is a Greek term meaning stop breathing. So when the airway obstructs, when the tongue falls back against the upper airway, the patient's obstructed his airway and there's no breathing. And that's why we call it an apneic event.
Okay.
Right, and that'll happen many times throughout the night in patients with sleep apnea.
So what happens is that back of that throat or something in the throat falls over the airway and you're actually struggling and trying to breathe, but you can't.
Correct.
Oh boy. So how do we change that around? How do we, all of us, do we like jump out of bed and wake up, or somebody has to shake us before we take the next breath? What happens that we can continue to breathe in after stopping?
Sure. During an apneic event, the oxygen goes low and it triggers an event in the brain. The brainstem realizes, hey, this guy has stopped breathing. And it triggers what's called the arousal response. And the patient actually comes out of sleep for 2 to 3 seconds and you'll hear the loud as the airway opens up, his tongue comes flying forward and he'll start snoring again. Most patients with sleep apnea do have quite heavy snoring. In fact, all patients with sleep apnea have snoring. So they'll start snoring and then all of a sudden the airway will close off again and he'll snore and there'll be no breathing. The airway's obstructed. But thank God for the arousal response, you come out of sleep and you start breathing. If you didn't come out of sleep and it went on for 3 to 4 minutes, you could actually die in your sleep. But anyone over 1 year old or over has an arousal response. And most kids under 1-year-olds also have it, but we have the arousal response. We pay a price for the arousal response. If we stop breathing 30 or 40 times per hour, that means we have to arouse 30, 40 times per hour. So you're coming out of sleep 30 to 40 times per hour, and the next day you're so tired because your sleep has been very disrupted.
Now, how do we get it? I mean, you know what I mean? How does it occur, that we have this person has obstructive sleep apnea, but this person doesn't? Is there a formula for this, or why does that person have that particular problem?
Usually there's certain anatomic abnormalities or anatomic obstruction of the upper airway, whether they have large tonsils, a large tongue, and obesity plays a major role. About 80% of our patients are obese. So not only we are obese over here in our stomach or our arms, the obesity extends to the neck and throat. and thus the airway is narrowed from the obesity. And thus, patients who are obese, when they lose weight, they have an 85 to 90% cure rate because the airway opens up more as you lose weight, as the fat tissue shrinks in the upper airway.
Now, are there other things in the airway that may close off your airway as well, like your adenoids or your tonsils or whatever those little things are back in the back of our throat?
Absolutely. Anything that obstructs the airway from the tip of the nose down to the trachea can lead to sleep apnea. The most important ones in the throat are the tonsils, and this is seen in adults, but mostly in the children. A large portion of our patients at Newark Beth Israel and all sleep centers are children, so they come in with the giant tonsils and they have sleep apnea. When they take out their tonsils, a tremendously high cure rate. A large uvula, that little punching bag in the back of the throat, that also can cause sleep apnea. A low soft palate, which is where the uvula is attached to. If it's low down deep in the throat, that can lead to sleep apnea. A large tongue. Some people have very large tongues. And that also can lead to the obstructive sleep apnea syndrome.
Oh, goodness. All righty.
Yeah.
Now, can I get rid of it? I have it. I want to get rid of it. Okay. It's gone. Thank you very much. Don't come back.
Right.
Can you get rid of this thing?
Yes. Again, if you have, let's say you're a child who's 5 years old and have big tonsils, you take the tonsils out and it has about a 90% cure rate.
Okay.
If adults, if you're obese, as I said, weight loss, 85 to 90% cure rate, depending on which, on which study you read. And there's also other treatments which include nasal CPAP. But it's important also to recognize the problems that occur with sleep apnea and why you want to get rid of it. For instance, it causes daytime sleepiness. As I said before, you have multiple arousals during the night. And arousal the patient's not aware of. They only come out of sleep for 2 to 3 seconds and then go right back into sleep. It's not an awakening. But the multiple arousals cause the patient to be so tired. So they're falling asleep at TV, reading, work, etc. Their social life and occupational life can be ruined because of the daytime sleepiness. It also can cause problems because the oxygen falls every time you stop breathing. And it can lead to high blood pressure. The heart and the brain need and love oxygen. Without it, you're prone to heart attacks, heart failure, you're prone to abnormal beats of the heart, and you're prone to strokes. And so it's important, therefore, to try and get rid of the sleep apnea.
Right. Now, is there a difference as far as developing this problem with children or adults or seniors? Is there more preponderance for one group to have it than the other?
Okay. Usually you'll see an increased incidence of sleep apnea with aging. So the older you get, the more prevalent it is. Sex, males will have it more than females, except after postmenopausally, females start catching up with men. Children will have it again. That's a separate issue again with large tonsils. However, we're seeing more and more. When I first started in the 1980s, it was mostly big tonsils, and about 4 or 5% of our patients were obese. But as Michelle Obama has been talking about throughout the years, childhood obesity, she has it right on the mark. Because now, as the years have gone by, I'm seeing like 10, 15% of our children are obese, and that's contributing to their sleep apnea. So not only do we have to think about tonsils, we have to have the children losing weight as well.
All righty. So let's touch on this again. Risk factors. I love those words. The medical words are so cool, you know what
Absolutely.
Risk factors. Tell me about the risk factors. I know obesity is one of them because you touched on that
Obesity, aging population, male sex predominance. It covers all races and nationalities, a little bit higher in the African American population, but it covers all nationality and races as well.
All righty. Okay. What about things like smoking cigarettes, or would that be a risk factor, or things like I like to go go out on Saturday night and have a few use my old elbow.
Drink over there.
Little drink with the boys, or something like that. But does that affect it as well?
Absolutely. Smoking increases the apneas and makes the oxygen fall more during the apneic event. So, and it also, what smoking does, the hot gases inflame the uvula and upper airway and thus cause more narrowing of the airway. So smoking is a risk factor. Anything that sedates you, alcohol, sedatives, narcotics, and sleeping pills make apneas worse. They cause more relaxation of the upper airway and cause more closure of the airway. So if you have sleep apnea and you have alcohol, sedatives, narcotics, it can make the apneas double. So instead of 20 apneas per hour, the patient may have 40 apneas per hour after having alcohol, narcotics, or sedatives.
Okay. Going back to this obesity, I just want to get this idea because it seems to be a very important aspect of this disease. You mean because I'm gaining weight, like if I'm obese or if I'm morbidly obese, I gain weight outwardly?
Yes.
But that means I'm gaining weight in my airways, or I'm narrowing my airways because it's getting larger in there. Well, I'll put it this way, it's getting fatter in there and the airway's getting narrower or smaller?
Precisely. Many studies have shown neck size, a larger neck size than 16 inches associated with sleep apnea. The upper airway also gets fatty tissue deposited and it narrows the airway. As I said, anything that narrows the upper airway will lead to sleep apnea. And that's why, again, when you lose weight, the fat goes away, the airway widens, and the apneas melt away in the majority of cases.
Okay. Let's talk about stages of sleep, because I know I hear that there are several stages of sleep. Describe those for us and give us an understanding of what that's all about.
Sure. There are 4 basic stages of sleep. There's non-REM sleep, which is stages 1, 2, and 3, and REM sleep. When we go to sleep, we start out with stage 1 sleep. We have about 4% of the night in stage 1 sleep. It's very light, and we barely perceive it. If we hear a little noise, we'll say, oh, what was that? I wasn't sleeping yet. Finally, after about 4 minutes, we'll hopefully go into stage 2 sleep. It's good sleep. It's not great sleep. It's good sleep. And we spend half the night in stage 2 sleep. After about 20 minutes, we'll go into stage 3, N3, non-REM sleep. And that's great sleep. That's where an earthquake could occur. You don't wake up. You're such a deep sleep. And it's very good body restorative sleep. If you have great deep sleep, you're going to feel great the next morning. Then we go in finally after about 90 minutes into our first REM period, REM sleep. REM sleep is a lot of stuff goes on. And it's dreaming sleep. And we're paralyzed during REM sleep. And there's a reason for it. We dream during REM sleep and we don't want to act out our dreams. Because if we did act out our dreams, we could hurt ourselves and hurt others. In fact, there's a disorder called the REM behavior disorder where we lose the paralysis during REM sleep and we actually act out our dreams. These people hurt themselves and hurt each other. Other people in the bed, their bed partner. So it can be very dangerous. Yeah.
Now, it's interesting. You said several things. We're paralyzed during a stage of sleep.
Correct.
Why does the heart keep beating?
Okay, certain organs don't get paralyzed. Those will be the skeletal
You're
muscles.
dead, you're dead.
You're dead, REM sleep, that's it, call it quits. No, during REM sleep, the muscles, our skeletal muscles are paralyzed, but the diaphragm can never take a day off. Your heart and your diaphragm, from the day you're born to the day you die, they can't take a vacation. So they keep going. Okay. But you do lose muscle tone of your chest wall muscles, which make you breathe a little more shallow during REM sleep, and the muscles of your upper airway become more collapsible. And that is why during REM sleep, apneas are usually worse. So many times we'll see apneas double the amount in REM sleep than in non-REM. We'll say the patient stopped breathing 40 times per hour. But during REM sleep, it was 70 times per hour, and during non-REM sleep, only 20 times per hour. So REM sleep is a dangerous portion of the night for apneic patients.
Okay. What about snoring? All righty. Now, I know, let me ask the first question. Is snoring always a part of obstructive sleep apnea?
Yes, it's always a part of sleep apnea. All sleep apnea patients snore, but not all patients who snore have sleep apnea.
Oh, all right.
Yeah.
So if you just snore,
right,
are you okay? That can't hurt you, right?
Snoring probably cannot hurt you.
Okay.
Some studies may show that maybe a slight increase in strokes, but it's very early on. But right now, we don't aggressively treat what we call primary snoring without sleep apnea. Okay. Except for if it's bothering the spouse, and the spouse may want to hurt you.
I hear you.
Yes.
Now, as far as apneas are concerned, or apneas, or the sleep problems, are they? I know there's obstructive sleep apnea, but are there other types of sleep apnea that may not be obstructive?
Sure. There's also something called central sleep apnea. In this case, the airway remains open. However, the brainstem, the part of the brain that tells you to breathe, forgets to send the signal down to the diaphragm to breathe and move. And the patient just sits there like this. They're not obstructed. And it's an apneic event, and it can, of course, the oxygen can fall there. And that's usually seen in disorders such as heart failure, strokes, severe diabetes, other neurologic diseases as well.
Oh, all right then, all right.
It's much less common.
All right then, all right. So we know that obstructive sleep apnea is fairly common in the general population.
Correct.
All right, all righty. And can it be truly dangerous? I mean, I understand with that, you're stopping breathing, but is it really dangerous?
Absolutely. A very high risk, as compared to the general population. It carries risk factors for strokes, heart attacks, heart failure, dangerous arrhythmias, where sometimes the cardiologist, I know Dr. Mahdi is going to be on a future show of yours, cardiac arrhythmias that can be very dangerous.
Arrhythmias are?
Abnormal beats of the heart.
Oh, okay.
And you don't want abnormal beats to your heart. You want your heart to be steady.
Nice and smooth. Like a nice car, nice and smooth.
You don't want it sputtering.
Yeah.
Absolutely. And it can also lead to high blood pressure, and it can lead to a heart failure, and the arteries in the heart can constrict and cause, in the lungs, and cause what we call pulmonary hypertension. 25 to 75% of the population who have obstructive sleep apnea have high blood pressure, and that can cause multiple problems in itself.
Right. Okay. So I know that there are nighttime symptoms, and then there are daytime symptoms. And one of the ones that I'm grappling with is choking. At nighttime, you really, I understand stop breathing, but why does the patient have to choke?
Okay, what happens is he actually is choking. The tongue falls back, and there's no airway, so he's actually choking himself off. Usually the choking is seen by the bed partner. However, some patients do X%, 10, 20%, they do come in, I woke up with this choking or gasping sensation. Now, they may stop breathing 400 times during the night, but they may only wake up once in a blue moon with that choking sensation. But they don't even realize it's occurring every night, 400 times a night. But it's one of the symptoms that we do ask and look for. It's important.
Okay. What about having trouble falling asleep? Is that part of it as well? Or you just, as soon as you hit the bed, you're out?
Sometimes it can cause a sleep onset insomnia, where they have trouble falling asleep. And sometimes if they choke a lot, we have a few patients who really do choke a lot and wake themselves continuously through the night, and they have a sleep maintenance insomnia. They wake up so many times during the night that they actually sense it, that they're having the insomnia from the choking.
Okay. Can you hear yourself snoring?
Yes. Many patients, it's usually transitioning from wakefulness to sleep. They're watching a movie on TV in their couch, and they go into sleep, and then, oh, what was that? And they realize, oh my God, that was me snoring. Oh my God. And the wife says, see, I told you it was snoring, Harry. Absolutely.
Okay, all righty. Now, some of the daytime symptoms, like fatigue. Why are you fatigued? Why should you be tired in the morning?
Very important. One of the cardinal symptoms they present to us at a sleep center is with the fatigue. As I said, the arousals which cause you to come out of the apneic event, it's good. It keeps you alive, but you pay a toll. So if you stop breathing 40 times an hour, 40 times per hour, you're coming out of sleep. So your sleep is so fragmented and chopped up, the next day you're so tired because you did not have good, solid, continuous sleep.
I got you. So you never got a good night's rest?
No good night's rest.
Okay, all right. So what about, and I don't understand the correlation with depression.
Very important. People with sleep apnea can have decreased moods, forgetfulness, poor focusing, and it's also related to depression. If somebody also has depression, it can make the depression much worse. We've treated a lot of patients for the sleep apnea, and the depression markedly improved, and that was really gratifying to us. Yeah.
Now, I occasionally will have a headache, but not very often, but I never have headache. I never wake up with a headache.
Right.
How does that correlate with this?
Okay. Through the metabolism of oxygen in the body, we breathe in oxygen, it goes to the cells, and the cells use the oxygen. When they do, they produce carbon dioxide. The carbon dioxide then goes to the lungs, and we breathe it out.
Oh, carbon who?
Carbon dioxide.
What does my body have to do with carbon dioxide? What is this, a chemistry lab or something?
It sort of is. The cells are a chemistry lab. They use oxygen. Everyone knows you need oxygen to breathe.
Yeah.
But when the oxygen is utilized, the cells do produce carbon dioxide, which goes into the air, and the lungs have that specific purpose to extract and expel the carbon dioxide, so it doesn't build up in our body. If it does build up, so when we stop breathing during an apneic event, the carbon dioxide cannot be expelled because we obstructed our airway. So it builds up in our blood. When the carbon dioxide goes to the brain and it gets elevated, it causes the vessels in the brain to expand. It's called cerebral vasodilatation, very fancy word, but they're expanding vessels. When they expand in the brain, we could wake up with a morning headache. And that's one of the most specific symptoms of sleep apnea, morning headaches.
Interesting. So let's go through some of the associated diseases. You had touched on it before, but this thing with it was called pulmonary hypertension.
Yes. So every time you stop breathing, the oxygen goes low, and when the oxygen goes low enough, it causes the vessels in the lungs to constrict, and it causes what's called high blood pressure in the lungs. So like we can have high blood pressure. A lot of people have high blood pressure in what was called the systemic circulation. When they take the blood pressure on your arm, in the lungs you get high blood pressure as well, and that can have an effect on the heart and cause heart failure as well.
Oh, goodness, yeah.
Yes.
All righty. Now, I know that I was talking to one doctor, one sleep doctor, and he said that some of the patients, not some of the patients, but there was a patient in his office that he had a concern with driving and obstructive sleep apnea. Tell me about this. How do we handle that?
Okay. Let me just start. There are laws in New Jersey, and proud that New Jersey was the first state in the whole union to pass a law called Maggie's Law. It says it's illegal to fall asleep at the wheel of the car, and if you do and get into an accident and hurt somebody or kill somebody, God forbid, you could be penalized with jail sentences, etc. They put upon us sleep doctors to ask the patient. We have to ask every patient by state law: are you dozing or falling asleep at the wheel of the car? Now, again, if they are falling asleep and they're a danger to the public, then we do have to report it to the state. But it's rare. Maybe one time a year we have to report it and they lose their license. And the vast majority, when we treat their sleep apnea, they're feeling great, then we get the license back for them. But it's a public health safety issue. Unfortunately, we have to do it because it's an issue.
I got you. So what you're telling me is you don't have a stack of license on the end of your desk there that you're showing everybody. Put it here, buddy. Put it here.
Thank God, no. It's a part of the job I don't like to do when you have to talk about the driving. But no, thank God it's rare. It's like once a year.
You don't have Ralph walking around the town without, and he took his license. He's got to walk from now on. Yeah.
We want Ralph driving.
Okay, good. Diagnosis. How do we diagnose? I know we got this bad problem of obstructive sleep apnea with so many patients. How do we diagnose this thing?
Okay, so we took the history. They find out the guy's overweight, he's snoring, his wife says he stops breathing, he has high blood pressure. He's a perfect candidate. So we bring him to the laboratory, hook him up to 18 electrodes, and we study him overnight. Then we score the study, and we see how many times per hour, that he stopped breathing. So the technician scores it, I then interpret it, and we'll go back to him. John, 30 times per hour you stop breathing and your oxygen went dangerously low. You have sleep apnea and now it's time to treat you so you don't get strokes, heart attacks, and daytime sleepiness. Okay.
What are some of the things that you monitor with this, what is it called? A
polysomnography.
Yeah, you got it.
Polysomnography, sleep study, and we monitor the electrodes for the brain. We look for every stage of sleep. We want to see the stage 1, 2, 3 in REM. We measure the airflow with a nasal cannula under the nose and mouth to see every breath they take. We're going to notice it. We measure oxygen with a little clip on the finger. We see how low the oxygen goes because that's very important. Remember, the lower the oxygen goes, the more dangerous it is. The heart and the heart and the brain love oxygen. Deprive them of oxygen, we're going to get problems. So we measure that, and we'll give a report to the referring doctor, and of course to the patient. This is how severe you are. This is how low your oxygen goes. Now we have to treat you.
Okay, all right then. Treatment. Let's get to the nitty-gritty of it. How do you treat these patients?
Obese, weight loss. We work hand in hand with nutritionists. Sometimes they even go for gastric bypass or gastric sleeve or lap band, etc. And we try to have lose weight. Again, 85 to 90% cure rate with weight loss. Fantastic. If they're children with large tonsils, take out the tonsils. Approximately 92% success rate with tonsillectomy for the children. If they are obese, and let's say it does take a long time to lose weight or they can't lose weight, we're going to use in the vast majority of adults, nasal CPAP. Nasal CPAP consists of a mask they use on the nose, in the nose, over the nose and mouth. And there are many great and comfortable masks on the market now connected to a compressor. It's a little compressor machine that forces air down the nose and throat and keeps the airway open.
Right.
They won't stop breathing anymore, and it has a 99.9% efficacy or success rate.
Right. So it's either weight loss or the mask or surgery.
And a combination of the three is often.
Right.
Yes.
That can cause
Right.
success rate.
Success rate.
Right. To get rid of this disease.
Exactly.
Dr. Nahmias, it was wonderful having you here. And I'm just so happy that you could explain it in a way that we all could understand. Thank you very much for coming and being on our show.
Thank you so much for having me.
A
true
much.
pleasure.
Thank you. All righty. Now, I would like to do a little Let's Talk segment. And this is the segment that I enjoy so much. Tonight, we're going to talk about blood pressure, because blood pressure is so important to all of us. I mean, blood pressure, extraordinarily high blood pressure can cause strokes, it can cause kidney disease, it can cause heart attacks. There are so many things that rely on blood pressure. It's phenomenal. So we want to make sure that your blood pressure is in a good range. Normal blood pressure, 120/80. And the 120 is the systolic. That's the number. That's the upper number. And the 80 is called the diastolic. And what we want to do is we want to keep those numbers somewhere below 120/80. If you get above that, then you have high blood pressure. You should go to your doctor, take your blood pressure regularly, and he just may put you on a medication to bring it down to a normal range. This is so important. It's so important that you take these medications, because if you don't and you have prolonged high blood pressure, those organs that I initially talked about, the brain, the heart, and the kidney, will have devastating effects. So what we need to do is we need to check the blood pressure, we need to eat healthy, we need to exercise, and we need to learn about your medicines and take them on time. Alrighty, in closing, because we're running out of time, okay, remember, sharing and caring, right? www.medmoments.com. Email me, let me know what's going on out there, and tweet me at medmoments. Never institute any change in your medical therapy before you consult your physician. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Good night.